good afternoon, everybody. You are very welcome at the fourth breakout session of the day. This is blood tests from the lab to you with Dr. Annette Neylon. Annette is happy to answer any urgent questions during the presentation, but otherwise we'll do questions at the end and would appreciate if we can give you the microphone for those questions because that makes it recorded for people to watch later on at home. My name's Nikki, I'm one of the Wellington support coordinators. Forgot to say that earlier on. And lovely to have you here, Annette. Annette Neylon completed training in haematology in Newcastle upon Tyne in the UK in 2003, obtaining fellowships of the Royal College of Physicians and the Royal College of Pathologists, as well as completing an MD in the field of chronic myeloid leukemia. She worked as a specialist haematologist in the UK between 2003 and 2007, before moving to the Southern Blood and Cancer Service in Dunedin as clinical lead of haematology. She has acted as principal investigator of several clinical research trials. In addition, in 2018, Annette has become member of the RACP New Zealand Joint College Training Subcommittee for Haematology, helping to promote training in haematology in New Zealand. Annette accepted the role of New Zealand Counsellor for the Haematology Society of Australia and New Zealand in 2021. Since 2022, Annette has worked for the New Zealand Blood Service, combining haematology and transfusion medicine. When not working, Annette functions as a taxi driver, event organiser and sideline cheerleader for her son. We're very grateful to have you join us today. Thank you.
Thanks. So we're going to just take a journey through what happens to your blood from when it's taken from your arm all the way back to what you might receive in the way of blood products. As you've heard, I'm a haematologist for more than 20 years and a transfusion medicine specialist now. So early on, back in the 1940s, it was a case of doing one sample at a time. I hope you noticed that the writing is equivalent or is appropriate for the age, but literally for every blood test that we had to do, we would need to get this sort of rule out, check a blood, put a blood drop on, look down the microscope, count cells ourselves. Quite time consuming and laborious. So back in the 1940s, as you can see, patient identification was not quite as it is today. We had a surname, that was all. And interestingly, this was for Dr. Diath, who was a worker at Otago University. And you were lucky if you got a blood count back 2 days later and all it told you is how many red blood cells you had there. Well, we have improved a little bit because then we started being able to have a little look down the microscope and see how many proportion of white blood cells there were there for us to look at. A little bit later, in the 1960s, we progressed so that we were giving automated blood counts. That meant that each individual one didn't have to be looked at by one of the laboratory technicians themselves. So whereabouts are we now in 2023? Well, the usual scenario is that the request comes from the day unit. We need a blood count. This person's having chemotherapy in 30 minutes. Do your best, okay? So the patient is bled, the sample is registered on the laboratory system electronically from where they are, and blood is sent to the laboratory. So for a haematology sample, you'd probably be quite familiar with these lavender top bottles. So these contain an anticoagulant to make sure that the blood doesn't clot before it arrives in the laboratory. But each time you might notice they take 3 or 4 different bottles and they're all different colours. And that's because they have different solutions in each one. And each one goes to a different part of the laboratory. We can't share samples that easily. So they all have a different destination and a different purpose. But that means that if your doctor hasn't asked for X particular test on a particular day, it's not going to be done. So this is a cross-match sample. So it's pink. And the vital thing here that you can help with is we have a saying which is, if it's pink, use ink. What that means is you can't put a sticky label on this. This is a cross-match to make sure you get the right blood for you and only you, and that there's no mix-up between your blood and the person sitting in the chair next to you. So the person needs to ask you to give your name, date of birth, and if you know it, because lots of people memorize it, your NHI, or they check your wristband in order to get the details right. So if you notice someone with a pink bottle putting a label on, that's going to get rejected. So you might as well tell them to stop now and do it properly. So roughly in Dunedin Lab, which is where I work, there are over 1,000 samples come through each and every day. So obviously yours is important, but it's one of many. This is what our laboratory machines look like. So we get an urgent sample from a haematology clinic, no problem. They will receive that result in 90 seconds. That's how quickly we can do it. But we have to make sure that we're doing it carefully. We're giving you an accurate result. And some things do slow us down because we actually have to look at it. So for those engineers amongst you, my husband's an engineer, so I always have to show pictures about how things work. This is the back end of the machine, and this is where the samples go along behind the scenes. So your lavender top bottles here, this is a pierced cap system. It means that nobody touches that bottle. It's all barcoded and assigned to you, not anybody else, and each one is tested in sequence. The machine itself has like a computer dashboard, a bit like an iPad, and it gives us all of these data informations, which are numbers, telling us all the different types of red blood cells, the size of them, how much hemoglobin is in each of them. It tells us the size, it tells us how many platelets you've got, and then this part is to tell us about the white cells. So each and every time we'll get a printout like this. These are to help us because we do really good pattern recognition in the laboratory. So if we see a pattern like this, we're like, yep, that's good, that's all normal. But as soon as these go out of pattern and the curves look different, that triggers us to think more carefully. And we also have these things here, which are called scatter plots. And that tells us a little bit more information about types of cells. So this is white cells. So some of you will be familiar with the different sorts of white cells. So we have our neutrophils, and they're granulocytes. They're the ones that fight bacterial infections particularly. And if you're on chemotherapy treatment, this is the number that you kind of get more interested in because it tells you a bit more about how susceptible to infections you might be. And then we have monocytes, and monocytes go on, they're bigger cells, that's why they're sitting higher up here. So this is the size of them. And the monocytes turn into macrophage, and they do all the gobbling up of things as they've been destroyed. So the neutrophils will attack cells and destroy them, and then your monocytes and macrophages come along and eat them. Lymphocytes, you may be familiar with these. If you have a condition called lymphoma, you might have too many lymphocytes, and they might be anywhere on the spectrum of maturation from being really quite young and immature all the way to being the elderly sort. And we'll have a look at some pictures of those in a bit. These eosinophils, we don't have very many of those, but they're the ones that sometimes go up if you have hay fever or asthma or certain types of drug allergies. So they could be quite useful to us if we're trying to figure out, is this something because of how you're reacting to a drug, for example. So this is supposedly to tell you what's normal. Now, what you have to remember is when a laboratory sets a normal range, they test as many normal people as they can. Sometimes they grab medical students, sometimes they grab blood donors. If you're really unlucky and you work in the lab and you happen to be passing, they kind of get you at the same time. But that's all dependent on what is normal. However, what they do It's sort of a chart like this. They chop off the bottom 2.5% and the top 2.5% and call the 95% in the middle normal. But that doesn't mean that those 2.5% of people either side are not normal. It's just they're outside our range. So that's just to put it in perspective for you. So when we're looking at normal, there are differences between men and women. What a surprise. So men traditionally have a higher blood count than women. And there's a whole lot of reasons for that. But what it means is that we have to know not only your name, date of birth, but we need to know, are you a woman? Are you pregnant? Or are you a young child? Because all of those things will have different normal ranges. But if we don't have that information, we kind of just go with the regular. We can guess some people's sex from their name, but not everybody. The hematocrit is this interesting thing. I think you saw a picture of a test tube before in some of the talks that I've been in. So it's the proportion of the plasma, the fluid bit, to the proportion of cells. And ideally, we're looking for a hematocrit between 0.35 and 0.5. If it's above 0.5, it may be polycythemia, in other words, too many cells. But if you're anemic, then you might not have enough, and that hematocrit could be as low as 0.2. This MCV is the mean corpuscular volume. So that's a really fancy way of saying the size of the cells. So it's whether they're normal size. If you're above 100, you're too big, and if you're less than 80, then you're too small. So that's called microcytic when you're too small and macrocytic when you're too big. Another figure that we give is how much hemoglobin, so mean corpuscular hemoglobin, should be in this range. So that's the amount of hemoglobin in each and every cell. So you might have a normal size cell, but it doesn't have enough hemoglobin in it. And then we have normal ranges for white blood cells. And the total white blood cell count is a little bit dodgy because all they're doing is adding up the different proportions. Now, if you're at the lower end of each of these, you might be just below this normal range, so all of your things might add up to 3.9, but that doesn't really mean you're abnormal if each of the individual ones are acceptable. And then you can see that this number here is 10 to the power 9. So we talk about neutrophils, and some of you on chemotherapy might be familiar with the term, oh, you're 0.1 neutrophils or you're 0.5 neutrophils. Well, you're actually 0.5 times 10 to the 9. You literally don't have one neutrophil that's trying really hard to go everywhere. So that's a relief, I'm sure. And then we have platelets, and we have oodles of platelets. We have far more platelets than anything else because they're really, really small, but sadly, they only live about 5 or 7 days, and they're constantly replenished. So you might have too many, and you might have 500, or you might have 1,000 platelets, and that's generally a condition called essential thrombocythemia, which is a fancy way of saying too many platelets. Or you might be thrombocytopenic, which means low platelet count. And how low can you go? Well, you can go down to 1, but again, this is times 10 to the 9. So you haven't just got one poor little platelet with no one to stick to. So when the lab is looking at these, most of the cells, as you know, like we've had 1,000 samples through, we can't check each and every one. So the majority are checked automatically, and if everything's normal, it's just automatically signed out, and the people in the day unit will receive that blood count within about 90 seconds. So the only ones that we tend to look at are those that are abnormal. And then the computer does some fancy things and thinks about it and says, well, is this the same as it was last week? And that's what we call a delta check. So if you had exactly the same blood count as you had last week, it would probably release it because it'll say, well, nothing's changed. But it might say, actually, this is out of proportion with what we were expecting. We've got no good reason for this, so we need to have a technologist in the laboratory look at it. And it might be that a blood film is required. So the technologist looks at all this information and then decides, in our example here, we have a hemoglobin of 71. We've already said for a woman, the range is between 115 and 155, so we're looking about half of normal. And what does that mean? Well, you've got a reduced number of absolute number of the red cells, and they have a low hemoglobin carrying concentration, which means that they've got a lower capacity to carry oxygen. That could be that you're losing red blood cells, in other words, you're bleeding, that you haven't actually been producing enough, and that might be that the bone marrow is not making them well enough, or you're destroying them. So how do we figure out which of those three possibilities could it be for that low hemoglobin? Well, we tend to use the values that we get on the rest of the printout. So we either decide that it's microcytic, that's where you've got MCV less than 80, and the typical thing that causes this is iron deficiency. We could be macrocytic, so we've got really big cells, and there's a whole range of things that can cause that, but one of the commonest is alcohol. And then you might be just normal in the middle, and that doesn't really tell us an awful lot. So I'll give you an example that we can use and follow through as we go through the laboratory. Obviously, we're aiming to give a precise diagnosis quite as quickly as possible. So we have a 60-year-old in the emergency department with back pain. Hemoglobin is 100 grams per litre. They're slightly large cells at 102. The neutrophils appear normal and the platelets are normal. So we've got a macrocytic anemia, and the machine is telling us, well, we need to look at a blood film. So our technologists will make a blood film and then have a look at it. So we know what normal looks like. So these are white blood cells, but they're purple, sadly. But anyway, that's the stain that we put on them. So these are neutrophils, and they have funny little lobes to them, and we're looking ideally for between 3 and 5 lobes. And this is a lymphocyte, and it's supposed to look like that. That's its normal shape. And this is an eosinophil, so it's got pink granules in it. And that probably means this person might have a bit of hay fever or asthma. And then these are red cells, and you can see the shape of them I like to think of is like a frisbee. Okay, so the middle, this is like looking down on a red cell, so the middle bit looks pale, but the outside is like, so it's what's called a biconcave disc, and you're looking down through the middle, which is why the red bit in the middle, there isn't as much red in the middle. So you're supposed to have one that looks, that's normal. It's got about a third of the middle being white. And these are what our blood films look like when we've made them. We try and spread them so the very end is only 1 cell thick, because that's where we like to look. And this is one of our laboratory scientists. She's got 2 computer screens. She's got the microscope. She's got everything in front of her. And she's looking around to see if she can work out what might be happening. So this is the blood film from the person down in the ED. You can see that we've got lots of the right sorts of cells. We've got platelets, we've got red cells, but they're lining up a bit funny. It's like a stack of coins, which is a bit odd because they seem to be sticking to each other. And it's happening not just in one place, but in lots of places. And we're not really meant to see that. So these little purple things are platelets. So in the bone marrow, we have megakaryocytes, which are great big things like plates. And then these little tiny fragments come off it, and that's what forms platelets. So that's what they are there. And we've already said that if you have too many red blood cells, that's polycythemia, and the marrow's producing too many. And too many platelets is called essential thrombocythemia, where you've got too many platelets. We might be able to look down and see immediately, well, this doesn't look quite right. Our red cells have got too much white in the middle of them. So this is a microcytic anemia, and this is very, very typical of what we see in a very severe iron deficiency. And then lo and behold, we give them some iron, and this happens, which is we've still got these ones that were like this here, but the new ones, these are younger, they're coming through and they've got the right amount of hemoglobin because the iron has already started to be incorporated in them. And we would see this within about 5 days of someone starting iron medication if they were iron deficient. So that's good. These are all the different types of white blood cells, and obviously we don't just learn what things look like down the microscope in a day. There's, you know, experience and expertise that comes with time. So neutrophils, we've already talked about, they're the ones that fight bacterial infection. Eosinophils, we tend to see in allergies or drugs. The monocytes, they turn into macrophage and eat up things. And then lymphocytes, which usually fight viruses particularly. You can have too many of them though. And too many of these sort of mature looking lymphocytes like this, they're still normal size. That might be a sign of a chronic lymphocytic leukemia. So we then look at what's happening inside the neutrophils. So this is normal. It looks quite healthy. It's got a few dots, but not too many. And it's got normal number of lobes. And you can see here, this has eaten something. Well, this is meningococcal disease. And you literally can see it down the microscope. And that's an immediate phone call to the person looking after that person saying, this person needs help straight away. Get them on the antibiotics. So you can save a life. And this is yeast. Now, clearly we don't want to see this, but very occasionally, somebody is overwhelmingly infected with a fungus, and we can actually see it inside their neutrophils. We might get toxic changes here, and that you can see they suddenly become really dark, really kind of menacing looking, and that means that they're trying to fight infections. And that's what toxic neutrophils will look like, and they're trying to be antibacterial weapons. Here, this is someone who's had their spleen removed. And normally the spleen acts like a big sieve and clears out all the bits that we shouldn't really have floating around in our system. But when the spleen's removed, it doesn't act properly. So you get all sorts of slightly weird and wonderful looking things. And these are called Hal Jolly Bodies, which is quite cute, really. But what it means is the little bit of nucleus that should have been cleared out before they came out from the bone marrow into the blood, they haven't been sieved properly. So we see all sorts of weird and wonderful like this if you had your spleen taken out. We hope we don't see very many of these, but obviously monocytes, as we said, they turn into macrophages and they try and eat stuff. So tuberculosis, this rather beautiful diagram here that looks like a flower, is actually really sinister because the macrophage has eaten the tuberculosis and it's trying to digest it. So that's not a good sign, particularly in a hematology patient. And we have these bone marrow macrophages which are trying to clear out. So sometimes we have an excessive amount of macrophage activity in the bone marrow. And again, that can tell us that there's something going on, which could be an infection or it could be something more sinister, and it's trying its hardest to eat it and clear it out. Now then, with the lymphocytes, that's what's providing our immunity. So lymphocytes go to the lymph glands and produce antibodies, and that's what we would normally want to happen. But sometimes we have very immature lymphocytes called lymphoblasts, and they grow. Usually they develop and mature, and these are the ones that fight back viral infections. And at the very end stage, this is literally about to ooze your antibodies out of this area, which has gone all pale here. So this is a plasma cell. But some of you will recognize that term plasma cell in that this is the abnormality that occurs in myeloma. And you have too many of these. So at the very early end of the spectrum, too many of these lymphoblasts that aren't supposed to be seen. This could be acute lymphoblastic leukemia. The middle, where they're sort of quite normally mature, that could be a chronic type of leukemia rather than acute. And then at the end, I've already said that this is the sign that you might have myeloma. Get my glasses back on. So going back to our question, so why does this 60-year-old have a macrocytic anemia, and is it connected to the back pain? Well, we have to think about all those causes that we've mentioned: alcohol, liver disease, deficiencies of B12 or folate, are they hemolyzing? Are they chewing up their cells so that the young cells are there and they're larger than normal? Or could it be something a bit more like drugs, medication? But we also have to consider myeloma and myelodysplasia. So they typically give you a very minor increase in size in the MCV. We need to go back and look, is this a new finding? Has it been seen before or not? And we also look at other things like liver function, your B12 and folate levels, your globulin levels, which is what we use to have a look at myeloma. Some other cells that we might be looking for, well, if you have an overindulgence of alcohol or have liver function problems, you have these things called target cells, and that's literally because they look like a target. They look kind of like a Mexican hat when you get them on the side. And these are called stomatocytes, after the mouth, because they sort of look like a bit of a slot in the thing. So sometimes morphology can be quite pretty. And then we can clearly, oh, sorry, wrong button. Clearly see here there's 1, 2, 3, 4, 5, 6, 7 lobes to this. So that's not normal. And that's what we often see if someone's got a low B12 or folate. So that could be someone on a vegan diet or someone who's had part of their bowel removed, so they're not able to absorb it normally. But that's an easy solution. We can replace that. So are there too many young cells? These are reticulocytes. Myelodysplasia, for those who may have popped along to the talk that I did earlier, these are just odd cells. They're not quite right. You can tell it sort of looks a bit unhappy, but it's also not got the right number of lobes in it. And here you've got a mishmash of too much hemoglobin, not enough hemoglobin, but they're not all consistent. And then the other thing that we saw on it was this sort of stack of coins, or what we call rouleau, and a plasma cell in the peripheral blood where we don't really want to see it. So continuing with the process that the technologist is doing, if there's a significant abnormality, then obviously they have to ask the laboratory hematologist to have a look. We might only see 1% of what goes through the laboratory. We don't look at normal anymore. Once you've trained, you don't get to look at normal. You have to look at all the abnormal and decide what's wrong with it. And usually we dig into your medical records, so we have a look on Health Connect, and it tells us what medication you're taking or what else could be going on, so that we piece together all the information, both scientific and clinical. So when we're having a look at this, we say, actually, there's a few plasma cells. Their kidneys are not working quite so well. And we've looked at the immunoglobulin levels. So that's sort of the same as like the antibody levels that you're forming. And it shows that we've suppressed, that there's a suppression of your immune system. So our first thought here is, this probably is going to be myeloma. So we recommend that you go to see a hematologist, because the person in the lab might not be doing the clinical work that week, and you need a bone marrow biopsy. So plasma cells spilling over to the blood is really quite unusual in myeloma, in that we don't often see them, but when we do, it's usually quite a long way along the spectrum. There could be some other abnormal cells that we might see. We've talked about fancy names, pseudo-Pelger-Hewitt. Sometimes we just make up names to make ourselves feel good, I think, really. But this looks like, you know, the old opera glasses. Like I'm peering over the top of my glasses at the moment. So pince-nez is the other name for these. And that's very typical of myelodysplasia. The one in the middle is a very ugly looking cell, and it's a myeloblast. So this is a very immature, abnormal myeloid cell and typical of acute myeloid leukemia. And this has got a rod in it. I don't know if you can see this pink line here, and that's just a crystal that's about to ooze out clotting factors. And that's why people with acute myeloid leukemia tend to have a lot of bruising and bleeding, because these are clotting factors that activate in your blood and cause your blood system to stop clotting properly. So this is never something that we particularly want to see, but we all look for. In the lymphoid line, we've got the same thing. You start off mature. This is an early lymphoblast. It's got these things called nucleoli, which sort of more of those are not good. And then lymphoblasts can be of large size or not so large size. So we get used to seeing these. We might see this condition called hairy cell leukemia, and I have to tell you that my very first patient, who was very infamous in the UK with hairy cell leukemia, he was actually sent down on the train to London because they wanted his blood, because hairy cell leukemia was only discovered in about the 1980s. And his name was Mr. Whiskers. And this is follicular lymphoma. If it spills out into your blood, then we could see cells like this, and it kind of looks a bit like a brain from the top. So those are typical. If we see those, we're thinking that could be follicular lymphoma. And then mantle cell lymphoma has got this sort of, they call it a fish mouth. So I don't know if you could get that, but there's sort of like a bit of a mouth opening there. So all of these things point us in the right direction, but we can't conclusively say this is the condition you've got until we've got the rest of the scientific tests. So the next test we're going to do is a bone marrow biopsy. And this is a CT of someone lying flat on the back. And we're going to do a bone marrow. So what we do is we turn them over into the recovery position, facing away from us, and that's so they can't reach back and hit us. And we're going into the right posterior iliac crest, so the bit there that sticks out with the bone marrow needle to get our sample. And the first bit is to get an aspirate, so the fluidy bit of the bone marrow, and we take about 1 to 2 mils and we kind of suck it really quickly. And then if we're good, but these days, you know, the youngsters, they're not quite the same as us old folk, I would make my own slides and I'd be like doing this and getting it, because it plots quite quickly. Now they take a laboratory technician who stands there ready to receive that little bit and make a beautiful slide from the start. So when I'm training registrars, I'm so mean, I make them make 200 slides. So that they could actually do this if they need to. If it's midnight and you have to go to the intensive care unit to see them, you're not going to get a technologist to come along with you. So you better learn to do it yourself. So we look at this, and again, we're aiming to try and get down to 1 cell thick at this end, so that we're looking at the whole spectrum of those. And on your left is normal. We're seeing a nice mix of all different cells. There's some big ones, there's some little ones, there's red cells, there's all stages of everything. So that's kind of normal. And what we're seeing here is that we've got very few of the other normal kind of cells like this. We've got all of the same cells that are big and blue and have like paler zones in them. And I quite like this because this is called an eccentric nucleus. I quite like being eccentric. So what it means is that it's off-center. And this is very, very diagnostic of myeloma. And this, for those of you that have a bone marrow, you might recognise as the trephine, or the core of bone that we take. And we put it in a cassette like this, and then they slice it so thin, so they get 300 slices per milliliter. I know. So again, we're trying to assess what that looks like. And this is what bone marrow looks like. So here we've got marrow cells, we've got the bony trabecular, and we're kind of looking for the pattern of it, if you like. And this is what it looks like when it's a lamb chop. So it's exactly the same structure whether you're human or not. Hopefully you don't get the lamb chop, although I was convinced in one of my anatomy exams I might have had a lamb chop. But this you can see for yourself. You don't have to be a scientist, but you can see it's lost all of its normal architecture. It's full of the same sort of thing, monotonous, and that's not normal. It hasn't got a nice mix of everything else. And it could be that it's very low in cellularity. So this cellularity here is between 5 and 10%, which is very low. Normal might be around, it depends on your age, 30 to 50%. But there's too many of the fat spaces. So this is when you've had your marrow cleared out and you're recovering from chemotherapy. But we have to time it well. We don't want to do it too early and get this because it doesn't really tell us a lot. So that's why sometimes we have to wait and only do it at the point where your blood counts are starting to recover after that chemotherapy. Sometimes we can see lumpy bits, and you get the impression that that's a lump, and that's a lump, and that's a lump. And this is very typical of lymphoma, in particular follicular lymphoma. It tends to look like this. So then we do additional tests, because we think we know what we're talking about and our experience tells us that, but really we probably should get the science. So we look for what we call the karyotype or cytogenetics or chromosomes. That's kind of, they all mean the same thing. So for patients, for example, with acute leukemia and for other types of cancer, this might inform us about what is the best treatment to give you. So using this example here, the translocation of 15, so chromosome 15 with 17, is only ever seems to occur in acute promyelocytic leukemia. It's about the only one that ever gets this. But what we know is we have a treatment that will affect that. So it may help us to decide this person needs that treatment, but we wouldn't use that same treatment in someone if they didn't have this. But it could be that there's actually a complex pattern, and that could be 3, 4, 5, or even more different abnormalities. And the more complex it gets, the harder it can be to get it, to get the right treatment. So this is what they look like when they're all lined up. We have to grow them. So sometimes we don't get a good enough sample, so it doesn't grow, so we can't actually do what we call cytogenetics. But it does remind me of a bit like organising your fields. And then you line them up in, or somebody rather clever lines them up and pairs them off because you have 2 of everything apart from, oh no, so this is a woman, 2 X chromosomes. If this was a man, you'd have 1 X and 1 Y. They're the only ones that shouldn't be paired necessarily. And they're arranged depending, given a number. And what this is determining is this part of 15 here has swapped with this part of 17. And this diagram shows exactly where you've swapped over. So this is what is called the 15-17 translocation. And you can see that directly, or the clever people who are used to looking at these can tell you that's the answer. But if this doesn't work and we can't grow these chromosomes, we've got other things we can do. So this is what's called FISH, or fluorescent in situ hybridization. So what you're doing is you're putting a green probe on one chromosome and a red probe on the other, and then you light them up. And in this particular case, you've got the green and red together in 2 places. So this is a fusion between 15 and 17. So this means you don't have to wait while the chromosomes line up. No kidding, they don't line up, but while they grow. So you could get this result within 24 hours. And that means that you can get onto the correct treatment as soon as possible. But what we can do while we're waiting is do flow cytometry. So each type of cell, whether it's a B cell, a T cell, or a neutrophil, has specific markers like bunny ears that stick up from the cell, just as you've got here. So each B cell has CD19 on it. Each T cell usually has a CD3 on it, and a neutrophil has 33. And what we do is mix these up with something that sticks to these and lights up, and then with each type, when it goes through our light source, it tries to record and document what type of cell's gone through. And it's like, oh, I recognise that. And we can count up to 25,000 cells per second. So I'm amazed that my slides work like that, so it's great. So each type of problem has a very distinct collection of documented numbers. So we know that acute myeloid leukemia, we look at CD33, 13, and myeloperoxidase, and that tells us this is acute myeloid leukemia. But if we think it's actually more to do with monocytes, then we might do a CD63. If it's lymphocytes, we're looking at 10 and 19, and then certain types of lymphoma, we're looking at 19, 3 for Ts, kappa and lambda. So the patterns are what we know and what we use to diagnose. And in acute myeloid leukemia, if they're normal cytogenetics, it could be, some of you would have heard Peter Browett talking about the library. the books might be there, but we need to see the spelling mosaic on page 102. So we do more detailed tests. And that comes down to telling us single point mutations. So we now know what the patterns in everybody's human genome is to tell you where 1 point mutation can make the difference between having myeloid leukemia, which is FLT3 positive or NPM1 positive, and not having it. And what that means we can use it for is targeting the treatment to that particular abnormality. And some of you who are in the chronic myeloid leukemia talk would know that BCR-ABL is absolutely only seen in chronic myeloid leukemia, and we now have a magic bullet. It was on the front cover of Time magazine in 2001, which is Gleevec or imatinib therapy that only targets this problem. So it allows us to learn more about what happens in the biology of the bone marrow, but we can use that to target drugs. So we like to produce an integrated report, so it's got information on what we see in your peripheral blood, what we see on your marrow aspirate, your trophine, and then all these other scientific tests. So now that we've got that, what are we going to do? Well, this is where my transfusion hat comes on. So we can replace certain things. So there are components of blood that we can transfuse. And just to put this in context, the average adult male will have a blood volume of around 5 to 6 litres. A female between 4 and 5 litres, but pregnant women increase proportionately their plasma to red cells. So they get kind of hemodiluted, but their total volume could be as high as 7 litres. And then a poor wee child or a neonate, they probably only have around 75 to 80 mils per kilo. And I find that really hard to put in perspective, so I've put this slide in for you so that you can recognise what we're talking about. So your average coffee cup size is a newborn babe. A 10-kilo child is around about 800 mils. A man of 80 kilos, 6 bottles of 6 litres. And the delicate woman of 62 kilos is around 4. What can we replace? Well, red, so red blood cells correct anemia, and they carry oxygen, so it improves your tissue oxygenation. The gold is plasma, so it restores your ability to clot, and it either helps with the platelet plug or the fibrin net catches everything together and starts the clot forming. And then we also provide quite specialised bottles of support. So some of you may receive immunoglobulin therapy, which could be given either intravenously, subcutaneously, or even into the muscles. And these are very specialised forms of immunoglobulin, like if you need rabies or you've had a needle stick injury and you need hepatitis B replacement, we make special immunoglobulins for that as well. We have to give people coagulation factors. So that could be a haemophiliac who needs special factor VIII concentrates in order to live completely normally and manage without bleeding. Albumin replaces the sort of stuff, the proteins in your blood that keeps the fluid in the right place and stops you getting really puffy ankles. And then pregnant ladies, obviously anti-D, if you're RhD negative, you need to be looked after and make sure that you're not sensitized, and therefore we can give you anti-D. Each of these components that we give have a different shelf life. So red cells live about 35 days, but they have to be stored in the fridge. And we actually don't give you much plasma in that. It's suspended in a solution that keeps it all nice and happy. Platelets have to be kept at room temperature and agitated. What that means is they're rocked all the time to stop them sticking together. But they only live 7 days if you're lucky. They have a 7-day shelf life from the time that they're taken from the donor to you receiving them. So we obviously need more and more donors to keep on doing that very regularly. But it also means that you might need platelets every week or twice a week, whereas the red cell transfusion you might only need every 3 or 4 weeks. And then we've got the other gold stuff, which is plasma, and we store it at -25, so it's frozen to keep the coagulation factors working normally. But it means we've got to have time to defrost it. And cryoprecipitate is it's a very fancy form of plasma, which particularly replaces fibrinogen. So if you're a pregnant lady having a postpartum bleed, you might need some of this to help you clot. Some of you granulocytes, or neutrophils as they're otherwise called, everybody's like, well, this is the only thing you never give me. Why don't you give me those? We can't, because poor old granulocytes or neutrophils only live about 7 to 12 hours. So by the time when they're taken from the donor, they're processed, they're taken in Auckland and they're flown to Dunedin, the majority of them are not going to be alive to do things. So it's a very specialised case that warrants having granulocytes. Okay, we'll get there. We now in New Zealand use universal leukodepletion, and that doesn't sound very exciting, but actually it gives us a much cleaner and safer product, and it means that most people who receive it won't have a high temperature or react to this. It kind of clears out the gunk that we don't want to have in a transfusion. My son is very proud that I have an irradiation license. But basically we irradiate it for certain conditions. It's to try and stop the donor's lymphocytes attacking the recipient's cells and causing what we call graft versus host disease. So we have to put it through an irradiator like this, and then the label actually goes black to show that it's been irradiated. The downside to this is it shortens the shelf life. So platelets, for example, once they've been irradiated, have to be transfused within 2 days. So it does mean that our capacity to keep going with these products, gets more challenging with logistics. So this is someone who's donating on a machine that's spinning off their plasma and their platelets. These are what platelets look like down the electron microscope. You can see them sort of like oozing out like this, and that's because they're activated and they're going to start sticking together. And this component that we give, which is like this little bit here, is the bag of platelets that we're giving you. And it corrects not only the number of platelets that you might have circulating, but also how they work. So sometimes you might be on medication that stops you clotting or interferes with your platelet function, and your numbers might be normal, but they're not doing the job. So sometimes we actually have to give you platelets even if your count looks normal, because we need them to help you form that clot. And this is the cryoprecipitate and FFP. Like I said, we store it frozen. We have to have time to defrost it.
How long is the defrosting process?
We have water baths. We have special ones. We have to temperature control.
I remember watching my
Probably.
cells be defrosted.
Yeah.
Ordinary water bath.
I know.
Microwave would be faster.
Yeah, it's not licensed. So around about 12 minutes. And then these are the hyperimmunes. So as we said, if you suddenly find that you've been in contact with someone with chickenpox and you're immunosuppressed, you might need zoster immunoglobulin to try and help you fight that, because your own immune system can't do it. Tetanus, people are familiar with that. So we supply this as well. And this is hepatitis B immune, so some people who in their work capacity have to be immunised, or people who are going to receive certain types of products that's going to leave them very susceptible. And then pregnant women, we don't want them sensitised because it means that it causes problems in subsequent pregnancies for the babies. So we give them anti-D prophylactically, preventatively. So just to run through why you might need a transfusion, well, we know that below 70 grams per litre transfusion is indicated, except if you have a very specific deficiency in, say, iron or B12 or folate, because that might be better handled by just replacing that particular deficiency. And below 80 grams per litre, we know that transfusion is generally beneficial because it helps you to carry oxygen around the body better. However, there might be instances where even between 80 and 90, or even 95 grams per litre, you might get some benefit, particularly if you were a frail person who had a heart condition. You might need to carry more oxygen. But each particular case has to be judged against how beneficial that would be. If your hemoglobin is more than 100, transfusion is probably not justified. And we're not aiming to return your hemoglobin to 120 or 130. You don't need to have that. What you need is enough to carry it around the tissues and behave and allow your body to behave normally. We can give platelets, as I said. Now, if you're a hematology patient and you're not significantly bleeding, you could tolerate a platelet count even less than 10. Now, it sounds like 10, but it's actually 10 to the power 9. So you've got a gazillion. But if you've got infection, you tend to consume your platelets much more quickly. And therefore, we have a threshold that's a little bit higher. So we tend to give you them if they're greater than 20. If you're a surgical patient and you need to go to theatre then and there, most surgeons are a bit reluctant to go in with a knife if your platelet count's less than 50. And certainly we do allow people like ophthalmologists who are going into your eye or your brain or your spine, near your spinal cord, to have even a few more platelets because it's quite a delicate area. And we might say you need to be closer to 80 or 100 in those circumstances. And then, as I've said before, you know, these cardiologists, they love their antiplatelet drugs, and they might have you on 3 different sorts of them, which is great for your heart. But if you start to bleed, it's quite difficult. Those drugs affect the platelets for as long as those platelets live. So sometimes we just have to give you another batch of platelets from someone else so that you can form the clot. I won't go into this too much, but basically fresh frozen plasma only really corrects your clotting factors for a few hours, so it's not something we give all the time. Very rarely there might be a deficiency of a factor that we don't have a concentrate for, and so we kind of give you this because we know there's some of it in there. Indications for cryoprecipitate, well, this is usually something that will replace your fibrinogen for up to 3 days, so a bit more longer term, and we tend to give 3 units for an average sized person. So that was a very brief and brisk run through what we can do. It's not always appropriate to give you every product that we have hold of, and we also have to be mindful about what unwanted effects you might experience from having a red cell transfusion, particularly if you're going to have multiple ones. We talked in the myelodysplasia talk about accumulating iron, because you can't easily excrete iron if you're taking too much in. And each unit of red cells that you receive gives you more than 10 times the daily recommended amount of iron. So over time, that sort of accumulates and can cause you problems. So it's about that balance between what's good for you and what potentially may have some harmful effects. So that's why we tend to judge it very carefully and make sure that it's appropriate to you. Thank you for your attention.
Wonderful. Thank you. We do have just a couple of minutes if anyone had a question they wanted to ask. Yes?
Not really a question, more of a statement. Some of us have blood tests every week of different various sorts. I always just assume as I hear nothing that everything's okay. Is that the best way to go about it? When is it good to see your blood test results?
Yeah, some people are fascinated with monitoring them, and now a lot of people will have these health apps so that the GP record, you know, you can log in and see all the records. Some people laboriously plot them on a thing and bring it to show you. I mean, the rule of thumb is that the person who requests the test is ultimately responsible. And it's difficult. We try and inform your GP so that they're aware of the situation. But actually, if the haematologist is the person asking for the test, they are responsible for it. And if there is something that is potentially serious, life-threatening, you would be contacted. Most haematologists receive their results electronically. They receive them the day that you have them taken or the day after at the latest, and they have to acknowledge them on the computer system to say they have looked at them and they've been addressed. So you probably are safe to say that if there was anything that really needed attention, then yes, you would be contacted. And you've got to remember, as I said, our lab alone processes over 1,000 samples a day. We can't contact everybody and go, oh, they were fine. you know. So so there is that element of what you don't hear probably means they're fine, but it's not wrong to be, you know, aware. And I think the important thing is that you know who to contact if you're not well, if you know that you're on chemotherapy that's dropped your neutrophil count, what to do if you experience any of those side effects that, you know, like high temperature or fever or feeling unwell. It's doing the important thing.
Brilliant. Thanks so much, Annette. We need to wrap it up at this stage, but thank you so much for joining us today for the second of your sessions. Watching those slides, I felt a sense of real appreciation for the years of study and research you've done to be able to give that sort of knowledge and understanding, but also appreciate you being able to present it in a way for us to understand today and even have the joy of learning about how jolly wallies, things like that. So thank you so much, and I've got a gift for you from us all. Really appreciate you spending your time with us today. Thank you.
Thank you. Oh, thank you. Thanks very much.
So it's now afternoon tea time. We've got half an hour, and then we all join into the main Savoy room for our last speaker of the day. Thank you.